I would like to call Dr. Somia Iqtadar. She is a physician by specialty, a faculty at the King Edward Medical University and Mayo Hospital, General Secretary of the Pakistan Society of Internal Medicine with contribution to multiple public health projects in Punjab and across the country. Welcome, Dr. Somia. Then I want to call upon Dr. Asif Imam. He is an immunologist and internist by specialty. He is a consultant at the Aga Khan University and South City Hospital. He is the founder and chairperson board of trustees of the SINA Health and Education Foundation. Welcome, Dr. Asif. Next, I would like to call upon Mr. Javed Ali Jagirani. He is an officer of the Pakistan Administrative Services, currently leading and transforming the People's Primary Healthcare Initiative in Sindh as its CEO. If Professor Javed Akram is here, sir, Assalamu alaikum. We'd like to invite Professor Javed Akram to please join us on stage. Sir, last page. He is the Vice Chancellor of the University of Health Sciences, the President of Pakistan Society of Internal Medicine. He has served as the caretaker Health Minister of Punjab, and he's a former VC of 𝐒𝐻𝐦𝐿 and has over 40 years of experience in the health system of Pakistan. I welcome all our esteemed panelists to this session, a very key session and the first session of this Health Expo on the global primary health care and the universal health coverage and where we stand. Pakistan is committed to achieve these Sustainable Development Goals by 2030. And today in July 2025, it is a critical moment to discuss the SDG 3, which is the health goal of achieving universal health coverage through primary health care. The theme of this conference, the Global Collaborations for Better Health, reflects the SDG 17, which is the goal of multi-stakeholder partnership. With this preamble, I would like to request Professor Javed Akram Saab. Sir, from your vast experience of academics and the health system, please enlighten us on the lacunae and the bottlenecks in the two key areas, the health policy and the curriculum. The National Health Vision 2025, what it was able to achieve, the upcoming National Health and Population Policy, how it will help us achieve the SDGs, and the impact of devolution, especially in the context of the curricular reforms required for bridging the HR that can support us in establishing the universal health coverage.
एक ही पॉलिसी को आगे इम्प्लीमेंट करे, बजाय इसके कोई नई पॉलिसी बनाए, पहले अंडू करे। तो मैंने उन्हें कहा कि जी आपने ही ये ऑल पार्टीज कॉन्फ्रेंस कराई थी टेररिज्म की, और तब उसके खतरखा रिजल्ट आए थे। अब आप ही ये मीटिंग बुलाएं तो वो हंसने लग पड़ेगा, ये तो हमारा काम ही नहीं है। मैंने कहा जी काम तो आपका है या नहीं है, लेकिन आप ही कर सकते हैं कि ऑल स्टेक होल्डर्स, ऑल पार्टीज, ऑपोजिशन, गवर्नमेंट, एवरीबडी, आर्मी themselves because they are in government also, so we should all agree to a health policy irrespective, और 50 साल की हेल्थ पॉलिसी दे दें कि जो आए अपना हिस्सा डाले, उसमें चेंज ना करे। So that is the only way I think that Pakistan should go.
Thank you, Dr. Javed. In the interest of time, I have to cut you a little short. So wonderful points by Dr. Javed Akram, that policy is really not the problem. It is mostly the issue of implementation, and short-lived policies do not work. They should be long-term policies which should be applied across the country by all politicians and all governance that come in. Next, I would like to request Dr. Khalid Shafi Saab. You have been spearheading many public health initiatives on your platform of the PPA, and especially in the childhood immunization category, and as the chair of the NITAG. So what are some of the main health and social issues that are causing these not so good indicators in child health, and how our current immunization program and the upcoming vaccines can achieve universal immunization coverage? And one key question is, what is your expectation as chair of NITAG? I would like to ask you, what is your expectation for polio and measles eradication in Pakistan? This is a very key thing.
Thank you. You have asked three things which each of which needs special attention and answer. First is the health indicators. Regarding the health indicator, although there is some improvement in the health indicators, our physical age has now in the 60s, it was in the 50. Our infant mortality rate was 126, now it is in the range of 67 and 80. Lekin, in spite of this, the rate of progress is not proportionate to the efforts. First of all, the efforts are only done in the curative side. Our health policy, health budget is mainly directive towards the curative side. Look at the budget of the Sindh in this year. Out of 350 billion approximate budget, only 16 billion is allocated to PPHI. This approximate figure, which covers 70% of the primary health care of the Sindh. And only one hospital, SIUT is given 18 billion, Indus is given 10 billion, a new hospital is built with 10 billion Larkana, and there is so much distribution of the funds all around. But for the primary health care, which is the basis of the health foundation, is so much neglected. Number one part is that. So, Dr. Javed Akram has rightly said that the government and the leaders are only interested in achieving the things. Today, if you immunize a child, the benefits will be evident over the next 20, 30, 40 years. If you counsel a mother about the breastfeeding, the result will come later. But if you make a heart transplant, kidney transplant, it will be very attractive to the people. One thing is that. So our health indicators are not improving as they should be. There was a plane crash of the PIA 2-3 years back. Now the people still remember. There is a plane crash of the Air Blue and other airlines, people remember. But daily, equal to 2 jumbo jet passengers number, children are dying in Pakistan. But attention is not being given to that. We have prepared a costed action plan for the newborn survival. Government has, Dr. Javed has rightly explained everything. We worked 2 years for making a strategy for improving our newborn mortality, which is the worst in the world. But the costed action plan is there, but it is not being implemented. Still, the government main focus is on the curative medicine, which gives early results. But this primary healthcare foundation will give later results in a long run. So this is a neglected part. This was your first question. And the second question was, remind me, that was about the immunization. Okay, the main issues which call number one is the lack of the civic infrastructure. For example, I give you an example. When this rotavirus vaccine was introduced in the EPI program, we were very hopeful that now the hospital will not be treating so many patients with the diarrhea. But still, our lack of infrastructure, good hygiene, sanitation, safe water, it is not being complemented with that. In the Western world, they have achieved attention on the health issues plus improvement in the civic infrastructure and the hygiene and the safe water sector. This is a total ignored part. Our first priority should be to provide the safe, clean drinking water to our people. There is no plan for that at all. Even the water is not there sufficient. So one factor is that. Other factor is that I have just explained that we are curative minded, not preventive minded. Second factor is from the other side, that is the demand. That is demand. There's so many good programs are there, but the people are not availing then because of the number one, poor literacy rate, lack of awareness, and lack of the sense of the health education. For example, vaccine program is there. The government purchases vaccine for every newborn who is born in Pakistan, but the utilization is less than 70%. There are other factors for that. Our misbeliefs is still, we have so many misbeliefs that of the people, we go door to door for the eradication of the polio, but the people refuse for that. So one thing is that, now coming to that, what is our expectation about the polio program, polio eradication, the measles elimination? Regarding if we take the program as a polio control program, this is a very successful program because there are very few cases of polio. But for the eradication, which is an absolute process, we have to go far beyond this. So much energies and so much funds are being allocated to polio program. even the Prime Minister, Chief Minister, Chief Secretary, everybody is committed. The Commissioner, Deputy Commissioner, Assistant Commissioner, Police Force, everybody is supporting to this program. But because of the misbelief of few thousand parents, still the virus circulating. But still, we have no option. We have to eradicate the polio because the whole world is looking after us. And we have not this option that we can ignore this. It's about the polio. Second is the measles. Measles is a killer disease. We, the pediatricians, know very well this is the worst of all the vaccine preventable diseases because it has significant incidence. Unfortunately, it can be easily prevented just with 2 doses of the vaccine. First dose is given MR vaccine at 9 months, second at 15 months. But our coverage, which is start in the range of 80-85% at birth, drops to less than 70% by the 9 months of age. And this figure is complemented by the high vaccine coverage rate in the Punjab and Azad Jammu Kashmir. If we come to Sindh, it is 69%. If we go to KPK, it is 60%. And if we go to Balochistan, it is 29% coverage only. So, but the situation is so disheartening on one side. On the other side, it is not that we, the health provider or the public health specialist, we have not given up. We are still raising our voices, and whatever places at the policy level we are working, we are trying best to overcome this situation. I give you just this example regarding the NITAG. NITAG is not an executive body. It is a group which is formed by the government of Pakistan to give the policy guidelines regarding the immunization to the EPI and the Ministry of Health. Regarding in my tenure, in the last 2 years, as a chair, what we have achieved, number one, on the top of that, we have included human papilloma cervical cancer vaccine in our EPI program. This is a great gift to the female children of Pakistan. Every year, 5,000 women who are suffering from the cervical cancer die because of that. We will be saving their lives. This is a great achievement, and this HPV will be rolled out in the Punjab, Sindh, AGK, federal area on the 15th September. Every female girl from 9 years to 14 years of age will be given this vaccine, and from the 1st January 2026, it will be included in the National EPI program. In the start of the 2025, KPK and Balochistan also will have the similar campaign. This is one achievement we have done to overcoming the measles, this so much high rate of the incidence of the measles. There are many suggestions. At an ad hoc process, we are going to have an SIA, special immunization activity in the November, where all over the Pakistan, we will be vaccinating the children from the 6 months to 5 years of age. So, after this, we are working, the NITAG is working on the measles elimination strategy, and we are working that we will control the measles to such a level that it will not be a public health problem. Still, it is the major vaccine preventable disease. The cases are there, the hospitals are most of the time flooded with this. These two are the main achievements regarding the NITAG. The NITAG Pakistan has recommended, first of all, I will want to share with you, now the NITAG has the vision that the vaccine for all ages, which is called the life course vaccination. Okay. Till now, the vaccination program was limited to the children under 2 years of age and the pregnant ladies. But now the NITAG has given the vision that all the people of all the age deserve vaccination, whatever is required. In the first step, we have recommended that the vaccination coverage should be increased to the 5 years of age. As an ad hoc measure, the big catch-up company is there. It is being done in Pakistan. And hopefully, this recommendation of the NITAG will be accepted by ministry. And by the 2026 start, we will be having children who miss the doses till 5 years, they will be eligible. I have 1 minute now.
We can have 2 more minutes later on, then we can continue with that. Thank you so much, Dr. Khalid. Very interesting insight that one side, the budget is an issue, that it is not directed to the right area. And on the social side, the literacy and the demand issues, and then the problems with the civic infrastructure. And it was wonderful to know about NITAG and how we can expand these suggestions and incorporate them. The next, I would like to invite Dr. Somia Iqtadar, and I would wanted to ask you, that Pakistan's current demography, it basically has a youth bulge and over 15 and towards the 60 years old. For any country, this is a demographic dividend, economically speaking. These people should be nice and healthy and contributing to our economic growth. However, in Pakistan, this age group is suffering from increasing prevalence of non-communicable diseases like diabetes and high blood pressure. And as they grow, they will not be able to contribute economically the way that any country can actually benefit from this. So what is your view about the preventive and gatekeeper role of primary healthcare as compared to the curative focus that we currently have in our country? And then how do you see that in this aging population, is the health system ready to cater to them? What do we need to do? Because when these people grow up with all these non-communicable diseases, there is a huge chunk of economic burden on the country. So I think you have a presentation. Please, can you help us start that? Thank you.
Okay. So thank you very much. Good afternoon, everyone. My name is Dr. Somia Iqtadar, and we are all aging. And it's one of the life's few guarantees that we will age with every passing day. But as communities live together, are we truly ready for what this means, aging-related issues? So today we'll try to cut noise, we'll talk real challenges, real solutions, and how primary healthcare must lead the charge for true universal health coverage. So let's get started. So let's talk about numbers, because they tell a critical story, right? So Pakistan has 16.5 million people aged more than 60 years. And that's nearly 7% of us. But look ahead. By 2050, that number rockets to 40 million. That's 12% of our population and almost double of today's reality. So there are two urgent details. Women, especially over 80, vastly outnumber the men. And it's not just that it is in the cities, it's hitting the rural communities hardest, where care is hardest to reach. And this isn't a future problem. It's unfolding right now, today, because in clinics, we see a lot of old age patients with multiple comorbidities, and not only in clinics, but in rural health centers as well. So, why is aging accelerating? This is the question, and this powerful trend tells us the story. So first, we are living longer. So life expectancy, it jumped from 60 years, which was in 1990, to over 70 today. But secondly, fertility rates are also different. From 6+ children per woman in 1990 to under 3 today. Fewer babies, but longer lives. And this is an aging tsunami. So by 2050, this curve shows a 40 million elders which will be waiting for care. And this isn't accidental. It's actually a demographic transformation. So these numbers aren't just stats. They are people, and our system is struggling to catch up with them. And let's have a reality check. Primary healthcare isn't built for seniors. When we talk about primary healthcare, it's usually mother and child healthcare or a younger population. No geriatric training, no tailored services. And over 60% of our older, we all know that they battle chronic diseases like diabetes, hypertension, ischemic heart disease, and increasing number of hepatitis and renal disease as well. So problems are emerging and increasing. And programs like, if we talk about Punjab, Sehat Sahulat, they fall short. They skip outpatient care and home health, and that's exactly what elderly population needs. So the families are drowning, especially the women, and it's a system failure. And what's the solution? Prevention, which barely exists. So we are reacting and actually not preparing for the future. There are no dedicated geriatric care facility in the country. This was stated in 2023 by Pakistan Medical Association. And that is so true. Geriatric care isn't taught in the medical schools. There are no specialized clinics for complex elderly needs. There is no structured training for post-graduation in the geriatric care as well. So the gaps are straining our entire system. This leads to uncoordinated referral systems. Rising demand for chronic diseases management puts a burden because these are lifelong diseases and they need a long-term care. There are weak social protection and many seniors face poverty, illness, which is a dangerous mix. And there are no long-term care models available. We improvise daily, and obviously, if on a daily basis you are doing this, that's unsustainable. So it's a flying blind. Without age-specific data or digital tools, we are just guessing and not saving. So this isn't just insufficiency, it's real lives in the balance, and we need to do something about it. I'm just trying to show you here about the international medical graduates in specialities in the USA. This is just to give you an idea when we compare it with Pakistan. That 51.2% that is for of the international medical graduates in US actually go to the geriatric medicine. This is more than all the subspecialties that they opt for their training. But the situation in Pakistan is completely opposite. There is just a handful of geriatric specialists for over 16.5 million elderly people. There are only two formal pathways which exist. One in 𝐂𝐚𝐿, which runs a fellowship program in geriatric medicine. And there is a CPSP-linked, Birmingham-linked program in UK where they provide training. So this is the progress, I would say, but it's a single drop in the ocean of need. We need every medical college training geriatric experts, and we need every district hiring them because the foundation is laid, and now we have to build on this by improving our systems. So how do we scale? With 4 non-negotiable pillars: education, clinical systems, policy, and research. If we invest in them, I think we can come up with something which can help us in the future. But we also need to know that UN has declared this is the decade for healthy and age-friendly environments, and that's our primary healthcare hubs and mobile units. So we have to combat ageism by training providers to value elders' dignity. We have to develop integrated care by linking clinics, homes, and social support. And we need to have a long-term care plan by piloting the community centers. So the Pakistan's action plans aren't optional, they are a global priority because UN also demands for this. So now let's build our plan to match the international standard. And we have to shift our focus on the health care instead of sick care. Unfortunately, we are treating patients and not preventing illnesses, which is the need of the hour. So prevention starts from the pre-geriatric care. So regular and moderate physical activity since childhood has to be encouraged. The nutrition services has to be improved. We have to tell our youngsters to abstain from smoking and alcohol and avoid self-medication. We have to engage them in healthy hobbies like reading, writing, sports, and listening to music. And in some countries, they have this financial security in adulthood itself program, which is an old age social and income security program with the name OASIS. So we have to start in the pre-geriatric if we want to improve the care of our elderly. So the primary prevention starts with health education. We need to improve immunization. We have to work on screening of chronic health conditions like diabetes and hypertension. We have to improve our dental services as well because they are also very important, especially in the elderly population. Exercise program, nutritional interventions, and in females and men also sometimes hormone replacement therapy is the need of the hour. Coming on to the secondary prevention, we have to screen for diseases like diabetes by doing a mass community level screening programs, because diabetes has become the #1 disease in the adult population in Pakistan globally. We have to have mammography or ultrasounds of the breast for the early detection of breast CA, pap smear for cervical carcinoma, chest x-rays for lung carcinoma, fecal occult blood and sigmoidoscopy is recommended after certain age, especially with a family history, for detection, early detection of colorectal carcinoma. Screening for ocular diseases, like if you have diabetes, screening for diabetic retinopathy or glaucoma, which is also very common in our population, and hearing evaluation. And these all come under the secondary prevention. Talking about tertiary prevention. So when illness strikes, recovery isn't just medical. It's just about restoring dignity we owe to our elders. So podiatric care, dental services, counseling, rehabilitation, this is all healthcare. So we have to invest in all of them in prevention and not in the cure. Geriatrics basically is not a single disease. It's about whole people with layered needs. And this is the 5M's global model, which includes mind, mobility, medication, and what matters most, and multi-complexity. We know that old age is accompanied by multiple chronic conditions, advanced illnesses, and complicated biosocial needs. So this all has to be kept taken care of when we plan geriatric services. So I will just give few recommendations over here that what needs to change. PHC reforms. So age-friendly primary care and rural mobile units, they can be a helpful step. Then training the specialists, launching of formal geriatric programs because skills matter, and expand the 𝐒𝐚𝐿 card-like programs covering home care, outpatient support, and filling the gaps. Then pilot the care centers, which is our community hubs for long-term needs, and we have to start locally and then expand. We have to invest in digital health, telemedicine for chronic diseases and mental health, because technology saves time, and data system. We have to track the data, monitor access outcomes and costs, and this will help us in the long run. So geriatric team is not only doctors. We need to produce not only geriatricians, but nurses, physiotherapists, health workers, social workers as well. So I will end here by saying that investing in equitable, age-friendly healthcare systems in low and middle-income countries in particular is just not a moral imperative, but it's an economic necessity. So when we empower our older population, it enhances the societal well-being and it builds the resilient communities for future generations. So are we ready? My answer will be not yet, but we can be. Aging is a success story if we plan for it. This is a cross-cutting issue, including health, gender, economy, and just not related to primary healthcare only. We must move from reactive to a proactive care model, and let's build systems that respect age, support independence, and promote equality. Thank you very much for it.
Thank you, Dr. Somia. Very insightful information that we have to build healthcare, not sick care. And our primary healthcare system is not built for the CDs and NCDs and not for, rather for maternal and child health. So let's move on to Dr. Asif Imam. So in our mixed health system, NGOs and CSOs have been filling up a major gap in the primary healthcare service provision. You, sir, have been the pioneer of utilizing an NGO platform for delivering quality primary healthcare services through the SINA initiative. What are the challenges and the successes for CSOs and NGOs to deliver universal healthcare in Pakistan at national as well as provincial level? Or what innovations or intersectoral collaborations are needed to engage the NGO sectors to achieve these SDGs? And what is the public policy vacuum in engaging the private sector for UHC and primary healthcare?
Thank you very much. My name is Asif Imam. And although I'm an allergy immunology specialist, but my passion is primary healthcare. And actually, I moved from the US to set up a robust system of primary healthcare. So, as we all know, WHO says that 80 to 90% of healthcare needs can be met at the primary healthcare level. And if you look at Pakistan, we're just the opposite. We don't have any primary healthcare system at all. That's where the fundamental problem is. And this is what we need to address, that our foundation is actually not good. We don't have a good primary healthcare. The good news is that PMDC's new leadership, they have actually sort of revolutionized the thought process of what a good primary healthcare system should be. And they are now totally focused on primary healthcare. The leadership has understood that primary healthcare ke baghair kuch nahi hoga. So right now, PMDC is trying to revamp the curriculum in which the training of the graduates, postgraduates, because there was no primary healthcare training post-medical school. Everyone was training in the hospitals. And obviously, as you know, hospital training and the primary healthcare training is very, very different. So now what they're doing is they are mandating each medical college not to just open a hospital, but 5 primary healthcare centers for training of the students and residents. So this is revolutionary. So the trend and the intellectual process has already started. But the problem is that is the first step. So you have to change the curriculum, emphasize on primary healthcare, which will cater to 80 to 90% of healthcare needs in Pakistan. If you look at any effective healthcare system like NHS or the Canadian system, they have a very robust primary healthcare system. And this is where we need to focus and develop. So the Sindh story starts in 1998 when I came back from the US and started to understand the primary healthcare system in Pakistan. And obviously it was very obvious that we need to develop a whole system, not just do things in silos, complete system. And we presented our model to the WHO EMRO region in August 2023 as a care model of a primary healthcare. And it was well received over there. And since actually before we presented it, WHO has actually come up with 10 levers, operational levers of how a primary healthcare system should work. So what we have done is we have taken that 10 levers and we have developed our systems according to that. And I think we, out of 9 of us, we can actually claim that we are doing that. So I think the first thing is you need a very robust model or a system with training. The good doctors are trained in that system. The second challenge was you can have a nice infrastructure, a nice clinic, and the nurses, but the nurses and the doctors are not trained for primary healthcare. So we have to revamp the training as well. And this is a very big task. This is something that I think our PMDC is starting to do, but I think even the medical colleges and the residency programs should start doing. So the system is number one. Second is training of the multidisciplinary approach. Like we all said that our system is doctor-driven. It has to be multidisciplinary-driven. The doctor cannot do everything. They need a support team to support and provide the proper care to the patient. So training ke baad, basically it comes on implementation of that system with accountability. So हमारे वहाँ ये होता है कि आप डॉक्टर को आपने या नर्स को आपने एम्प्लॉय कर लिया and then कोई पूछता नहीं है कि उसका परफॉर्मेंस कैसी है. So this is something, accountability has to come. Until accountability comes, don't expect any kind of quality of care. So we have worked on that in our system also. We have started with the audits of the doctor performance, and we have a very robust quality performance audit system for the doctors, and we re-educate them if they have any shortcomings. We train them. That's the third thing. The other thing is, this is age of digitization. We need a very robust 360-degree digital platform which will integrate all kinds of care. So we are in the process of developing a multidisciplinary digital platform, especially for primary healthcare, in which the doctor, the nurse, the nutritionist, the physiotherapist, the social worker, the pharmacist will have their own domains in which they can put their documentation of what kind of care they gave to the patient. So we have to move on to the modern technologies. And once we have done that, then we should work together, and then we come up with a national standard, like NHS. See, NHS is a national standard. We should work together, all the academic institutions and the NGOs and the private sector. They should come up with a national standard of primary health care. And then things are going to start happening. So that's my 2-bit.
Thank you so much, Dr. Asif. So a shift from the doctor-driven current model, accountability, digitization of services, and as we have gone through 4 of our panelists, I think all of them are agreeing that although there's 5 years left till 2030, but the primary healthcare has huge amounts of lacunae, and we are all aware of it. So we can definitely shift towards device policies to address them. Next, I move on to the primary healthcare systems, the public primary healthcare system specifically, and the maternal and child health services. So, Mr. Jagirani Sahab, who is the CEO of the PPHI, you have successfully expanded and improved the PHC network in Sindh, especially for the maternal and child health services. Please, can you share the public partnership model, this particular model, how it has evolved in Sindh, and how do you think that this model can be leveraged in our mixed health system to achieve the primary healthcare and universal healthcare coverage goals?
Thank you very much. Thank you very much. Yes, as far as PHC is concerned, with the perspective of this PPP mode, basically this public-private partnership, that's maybe if not that much new, but in the recent past, it's a new type of management model which has achieved good results in different sectors. So with this approach, government of Sindh applied this. Initially, federal government, all of the provinces, and then Sindh government, specifically in Sindh province, they adopted this approach in health sector and particularly in the primary healthcare side. So it really has brought good results and good fruits as far as primary healthcare is concerned, because I'll just briefly touch upon why it is so, because it is addressing system issues, basic issues with which our governmental public sector system was struck up with. Why it was not delivering, why it was health facilities in far-flung areas were not delivering. So it basically, this new model whereby PPHI is working under an MOU with the government of Sindh, it addressed those core issues which were inherent in those public sector health facilities. Number one, financing model. The government of Sindh came up with under this PPP model, we have a different financing model whereby one-line grant is given to PPHI. It is PPHI who has to decide, who has to prioritize funding allocation. Before this, it obviously was a different model, and prioritization was not being done. So this solution, this one-line single-line grant, really gave a space in terms of prioritizing the areas, geographical areas, services areas where by a true delivery can be done. Number one. Number two, then administrative independence. These were the two issues which were inherent, as I told you, as far as primary healthcare facilities were of concern of government of Sindh. So when I say administrative independence, here PPHI is totally independent to take administrative decisions in terms of HR hiring, in terms of aligning services, with the modern day, approaches and all that, which was missing earlier. So with these few but basic inherent issues addressed with this PPP approach, obviously there has been a topsy-turvy change as far as PHC is concerned. Once I share the results, I have maybe data when PPHI started some around 14 years back. Few of health facilities were handed over by government of Sindh for its management, and right now the number is 1400 plus, which means in terms of the coverage, we are managing 40% of primary healthcare as far as population is concerned, the whole of the Sindh. And in terms of rural Sindh, we are covering more than 60% of primary health coverage. So we basically came up with a new idea with same issues, and the coverage is day by day increasing. Geographical coverage is increasing, whereby PPHI is operating in all far-flung of areas of province of Sindh. Maybe it's tough areas, hard areas like Kashmir, Tharparkar, Kambar district. So we are everywhere in the whole of the province. In terms of financial coverage, analyzing services being given by PPHI vis-a-vis UHC, this is another important component of UHC, that in terms of financial equity, financial facilitation, the UHC services have to be provided, keeping the financial position of the patients also. So in their terms, PPHI is providing 100% all the services free of cost, which means addressing this particular issue of UHC. In terms of services coverage, we are focusing upon all the indicators which are covered under universal health coverage, all the priority indicators, which happens to be 30. In majority of the indicators, the PPHI is providing a comprehensive and 100% package, which happens to be around more than 40 to 45%. Around 30% of indicators we are giving partial services, and there are still 15 to 20% of indicators as far as UHC is concerned, whereby PPHI is not providing those PHC services. And obviously it depends upon government of Sindh. We have taken up this particular case with the government of Sindh so that a comprehensive package of UHC is provided to the population of government of Sindh. Having said that, the good thing is we have, government of Sindh has piloted one project at 𝐷𝐸𝐻𝐼, whereby a comprehensive EPHS project and package has to be given at 𝐷𝐸𝐻𝐼. That will be pilot, and the target is that the UHC coverage in terms of essential package of health services has to be comprehensive. All those indicators, the priority indicators in terms of service delivery at PHC health facilities has to be, the target is that all those priority services are given to clients, to patients at the health facility level. So this is really a good start, whereby we are going to digitalize services, we are making the service package more comprehensive. So in winding up my discussion, I will just say that obviously this PPP this novel approach has worked as far as primary healthcare is concerned. Number one. Number two, more efforts are required. Obviously, if the package has to be comprehensive, Sindh government, and we are negotiating with Sindh government, more health facilities, maybe 100% of primary healthcare health facilities have to be given to PPHI. And once that is done, hopefully this whole UHC package will be comprehensive in Sindh. Thank you.
Thank you so much, Javed sir. So administrative independence that comes with the public partnership model has been very successful in Sindh, and if we look into this model, it could possibly be something which we can utilize, and other provinces can also utilize this model, which is solving some of the key issues and being able to administer the 3 pillars of the universal health coverage. So for the second round, we have identified all these problems, and I think we are all agreeing to it with all your expertise. We all know what the problem is. Now, if you can all just give us 2 to 3 solutions or recommendations, what should be the direction of working now? in this time constraint of 5 years, trying to achieve universal health coverage through primary health care. Just 2-3 recommendations from each one of you. Sir, aap se kar.
Thank you. One thing I think we must keep in mind is that universal health care is not a luxury. It is right of every child that is born, irrespective of caste, creed, or pocket, or whatever. So far, whichever model you look at, private-public model in Sindh, this is not really a private-public model. It's more of a philanthropy-driven model. That you have people, because there are more industrialists in Karachi and in Sindh, and there are very, very rich people and too many poor people. So there are very good people who want to donate something to for the base of the pyramid. So that is being, I think, used. But if you go to the rural Sindh, which I have myself gone to rural Sindh many times, I think the coverage there is, nowhere near that we need to be. I think the universal health care in Punjab, they have tried to outsource it to the private, and they failed miserably. One thing the government must realize, or be made to realize, is that it is the responsibility of the government and not anybody else. So you cannot, provide universal health care or optimum health care to people with charity. Charity is add-on. You cannot shift your entire burden of your duties to the philanthropy center. You can only thank them for doing what they are. But they are not responsible. It's the government who is answerable to the people in what they have done. Unfortunately, I think what needs to be done is that we do have in Punjab, and I am in Sindh, rural health center, basic health units, but most of them are dysfunctional. They need to incentivize the human resource for health to go into these rural areas. Then they need to pay them double or maybe triple of that. So they need to populate that. Those buildings are now being used as, so somebody has started a school there, or somebody. So they are not really functional at all, majority of them. So I think to make them functional, the main bottleneck is the human resource for health in these far-flung areas, the security issues, which again it's up to the government to sort out there, and then non-functional equipment there. So and then the provision of medicine is not there. So that needs a good governance model. In Punjab, we have a model where primary health care is separate and tertiary care is separate, specialized care. It didn't work. I think it was much better when we had one health department. The most important thing I think that needs to be done, and during my tenure as a minister, we started that, is the referral system. If you have a referral system where you have catchment areas with your tertiary care hospital, the teaching hospital, and then because they are also public sector organizations, then shift the duties to them to make sure that there is adequate human resource for health, like for universities, medical universities, health universities, or for the medical colleges. We did a pilot where we attached few districts to a particular medical college, like 𝐒𝐚𝐫𝐸 Medical College, and then the consultants were going there weekly to the basic health units, and even surgeries were started and everything. But as always, once the government changes, everything changes. Unfortunately, so there was no sustainability, but the pilot did very well. 2 years pilot in these districts, Sahiwal and Okada, attached to one medical college, and that improved the situation there, the vaccination rate, the nutrition, which is a problem in children, as Khalid Shafi just highlighted. And these things, our problem is there is too much overcrowding. For example, I have been chief executive of about 12 major hospitals like PIMS. In PIMS, which is a university teaching hospital, we were doing 250 plus deliveries every day. So we are not a maternity home. So that is why I think the people look up to these tertiary care hospitals, because there are non-functional facilities next door. So that they need to be made functional.
Thank you. So 2 minutes में what should we do? क्या करें? 2 चीजें 3 चीजें क्या करें?
I will just add to what Dr. Javed has mentioned. Actually, our priorities should be focused toward the prevention. That is the only way we can get the universal health coverage. And the missing part is that all the attention is on the curative medicine. Even preventive medicine is not much taught as it should be in the undergraduate and the other curriculum. And in the primary healthcare, the missing part is the community engagement. And the community participant is still in the places where it is practiced. The community engagement is not there. In the Azad Jammu Kashmir, the community engagement is so strong that their 85% vaccination is done at the vaccine centers. The community is so bound that they do not miss any vaccination. Their coverage is more than 90%. But in the other parts, it is only 30% vaccine is done at the fixed center, while the vaccinator has to go door to door. So it's a community participation which is an essential part of the PHC.
Right.
It should be promoted. That is the way we can get good results.
Ji, Dr. Somia, 2 things we can do.
I think the key is the prevention, and we have to start with prevention if we really want to have universal health coverage with PHC. And the prevention has to start from the school-based trainings, nutrition, vaccination, and just from the grassroots level. Secondly, build up on the frontline workers. So we have lady health workers who are generally giving population control advice or gynecological services. They can be upscaled to screening for diabetes, for hypertension, for obesity, because these are the rising threat of non-communicable diseases. Then better data and digital tools. I think it is the area of digitalization, and without electronic records, it's not possible to make our policies. And finally, I would say proper referral between the primary healthcare hospital and the hospitals. That needs to be smooth and recognized.
Ji, thank you so much. Dr. Asif, what 2-3 things we can do?
Ji, I think if you really look at the theory, it is very simple. The problem is implementation. That takes time, money, and all that. So I think यहाँ बैठ के we can say कि ये कर लें, वो कर लें, but I'm afraid it's not going to happen. So I'll give you this simple, actually very straightforward principles, especially on the primary healthcare. And this is what I've basically learned from the WHO and working in the field. So you start at the basics. Our model of care is flawed. We need to develop a multidisciplinary, patient-centered, preventive model of care. Now that's very simple to say, but doing it is very, very difficult. So a model of care, we need to come up with a model of care which the private and the public sector agrees on and say, okay, this is what we want. Right now we have multiple models of care, and that's not going to work. Second is, training is the key. If you have a system and you put in the current nurses and the doctors to run that system, it's not going to work. So you need a very robust, multidisciplinary, competency-based training programs. So it is task-driven. It's not theory-driven. What you need to do, you need to train on that. So for example, A primary healthcare team, like I mentioned before, needs a doctor, needs a nurse, needs a pharmacist, needs a care manager who manages everything, right? You need a clinic supervisor who does the administrative work. So these are a lot of things that we need to do. So training, I cannot emphasize too much on training.
Okay, thank you. Sir.
Second, how do you implement it? Implementation में आपने ट्रेनिंग दे दी और उनको एम्प्लॉय लगा दिया, वो अपनी मर्जी का जो भी करना है. Accountability systems, that has to be there. And उसके बगैर आप quality दे ही नहीं सकते.
Great.
You know,
Thank you so
standardize
much.
quality of care. You need to audit that. You need to monitor it. If someone is not following it, they have to follow it.
Thank you so
right?
much. Ji.
Implementation. The other simple things is WHO has actually told us how to do it. So there are 10 operation levers of a primary healthcare center. You can just adopt that and implement it. And they're telling you how to do it.
Sure.
Right?
Sure.
So the solutions are there. We just need to get on it.
To implement.
Right.
Thank you so much, sir. Dr. Javed Saab, just 2-3 things that we can do, and then we'll wrap up this session.
Thank you. I have more things to offer, obviously, because since I am dealing with the PHC, and mainly all have been touched upon by my senior colleagues. Very importantly, increase budgeting towards PHC, as was mentioned by Dr. Khalid, because to prioritize PHC, the percentage of budget has to be increased. Infrastructure development, obviously, we are still lagging in the infrastructure. We don't have updated infrastructure who cater to the needs of modern the PHC demands. HR strengthening, very important. Dr. Asif has mentioned that training is very important, because without strengthened HR, we can't do it, and we have to incentivize, as has been said by Dr. Javed. What PPHI has been doing, like we have introduced third allowance at Tharparkar district, which is a very handsome amount, which is equivalent to one additional basic pay, and it's attracting doctors even from Karachi. Quality of care is very important. Continuous adaptation to modern protocols and standards, that's very important. Community engagement, because PHC can't be comprehensive without community outreach and without intervention for behavioral change. It's very important. Referral system was mentioned by Dr. Khalid, very important, because obviously PHC can't cater all of the services. So a robust referral system can save so many lives, and it can evenly shift the balance between primary healthcare and secondary healthcare. Finally, last not but the least, that is digitalization of the service, because without profiling we can't proceed. Very important in this modern day AI-based world, we have to digitalize services.
Thank you so much, Ji. So with this, we close our session with these esteemed panelists, and the wonderful part is that they all agree on the similar points that we need to do to achieve the universal health coverage in the primary healthcare SDG goals. With this, we would like to ask if there is any question from the participants, or we have time for one or two.
We have to,
Two questions?
Really sorry. Some questions definitely they would have been there.
Okay.
But
we want to wrap up the question. Okay.
May I request Professor Aftab Mohsin to please join us on the stage? Actually, Governor Sindh is on the way.
Okay.
Actually, he has reached. So we would like to distribute the shields, and then you have to.
Can I just thank them?
No, you can thank them.
आप लोग please stay seated. Yeah. Thank you so much, Abid Saab. अगर आप के further हमारे guest और chief guest are coming, so we will just modify this end of the session. Sir, please have a seat here. This session, and I'll hand it over to Abid Saab.
Ladies and gentlemen, I would now request Professor Aftab Mohsin, President PSIM, for giving away the shields to our esteemed panelists. I would also request Mr. 𝐂𝐚𝐿, CEO, Badar Expo Solutions, and Dr. Abid Abbas Sheikh, Organizing Secretary, Healthcare Expo, to please join him up on the stage. Dr. Zainab Hasan, Professor Javed Akram, Professor Khalid Shafi, Professor Somia Iqtadar, Dr. Asif Imam, and Mr. Javed Ali Jagirani. Thank you all for being with us.